Chanchalani. She is a consultant intensivist from Mumbai. The topic is ADRENAL, Step Towards Precision Medicine.
Good afternoon, everyone. And first of all, I would like to thank the organizers for inviting me over to such a beautiful place. And my topic for today is ADRENAL, a step towards precision medicine. So when I got this topic actually on email, I denied, or rather I would say I did not reply to the mail for confirmation of this topic and to confirm my participation in Reflect 2021. But and eventually after 4-5 days I just got the tickets, and then I had no choice but to read it up. And I read it up and I'm here, and I hope, the organizers, that I do justice to this topic. So to begin, when we see this topic, of course I did not understand at the first go, but when I researched, I realized that it is more of understanding what is the role of adrenal gland, or the role of giving hydrocortisone in sepsis as a step towards precision medicine in our critical care. So I have no financial or intellectual disclosures to make. To begin my topic, first I will say a quote from Mr. Mark Twain, where he says that history may not repeat itself, but it does rhyme a lot. And this holds true for most of the trials of low-dose steroids in septic shock. So sepsis, as we all know, is a dysregulated host response to infection. And we know that sepsis is common. We know that it is life-threatening. It is time-sensitive, and it is a major public health concern. Regarding the use of steroids in septic shock, till now the surviving sepsis guidelines gave it a minor recommendation for patients in refractory shock, but the 2021 surviving sepsis guidelines do not give any recommendation on using hydrocortisone or steroids in septic shock. However, in 2019, a Cochrane review of 61 trials with over 12,000 participants showed a significant benefit in terms of 28-day mortality with reduced ICU and hospital stay in patients who were given hydrocortisone in septic shock. So despite these varying results of studies that we were getting all over, the climax of this scientific dilemma occurred in 2018 when NEJM in a single issue published two large independent randomized controlled trials, mainly the ADRENAL and APRO-CCHS, where both the trials, though they had almost identical inclusion criteria, almost identical endpoints to begin with, they both had quite conflicting or contradictory results in the final published. And these both were, as I said, published in the same issue of NEJM in 2018. The differences that were there between these two trials were that they were, one was multinational or multi-center and other was from a single country. The ADRENAL trial had intervention of using only hydrocortisone, and the APRO-CCHS had an intervention of using hydrocortisone with fludrocortisone. The mortality in the placebo group also was different, and as I said, the results were quite contradictory, wherein ADRENAL showed no mortality benefit with use of low-dose hydrocortisone, but APRO-CCH showed a benefit of doing that. Initially, it was thought this is due to dysregulated adrenal response, that is due to the difference in the corticosteroid deficiency, or the deficiency of the hormones that was there. But when a sub-study of the adrenal cohort was done by measuring the plasma concentrations of the total cortisol and the free cortisol in the plasma, there was no such correlation that was seen between the mortality or in the mechanical ventilation days requirement when this was seen. So this was not dysregulated adrenal response. And we have also seen that in clinical practice that we often come across patients who have similar conditions, but we see a quite difference in the response that they have to steroids that we use in their shock. Some patients may seemingly have a dramatic improvement when we give them low-dose corticosteroids in septic shock, while others do not respond to them and continue to decline and not survive. So pre-identifying which of these septic patients will benefit from steroids is thus an obvious next step that we need to take. So how do we look at this? Okay, we have seen that trials are confusing, trial results are confusing, and after a lot of research, it was found out that it is the heterogeneity of the immune response in sepsis that has failed to stratify patients based on the current status that we analyze in the trials. So the old school of thought was to do trials based on prognostic enrichment. That means the patients were classified into groups based on the severity of the disease. Whereas the new school of thought believes in predictive enrichment, that means doing biological plausibility which is related to immune status to classify them into subgroups for the trial and for the analysis. A great milestone for this was when a trial was published in 2019 by Wong et al., wherein he analyzed, he studied pediatric septic shock patients and with very high sepsis severity and a very high chance of mortality. And he identified 44 genes based on which, on whose reduced expression of the signaling pathways, which was related to the immune system and the glucocorticoid receptor signaling, wherein he divided these pediatric shock patients into 3 subgroups, that is A, B and C. And this was an analysis of almost 98 pediatric patients. Of this, he found that the subgroup A had the worst outcomes. Then he reassessed another study which he did in 2016, where where he analyzed 288 patients of pediatric shock patients, and here he used both the strategies, that is prognostic enrichment as well as predictive enrichment, which we just learned about, to classify these patients into groups. So for the prognostic enrichment, he used a sepsis biomarker scale, which was the persevere scale, and for the predictive enrichment, he divided them into endotype A and endotype B. And what he found is that in patients who were in endotype B, based on the genetic analysis, he found that they responded well when they were given to corticosteroids treatment. But using these transcriptomes are not very easy; they are quite complex. And then another milestone study was published recently, wherein they retrospectively analyzed 3 important observational cohorts of sepsis patients, and they identified or divided these sepsis patients into 4 novel phenotypes. And they found that these phenotypes correlated well with the biomarkers as well as with the mortality. So the phenotypes were mainly phenotype alpha, beta, gamma, and delta, and these were not really the severity of illness, and they were not related to the site of infection. It was found that the alpha phenotype required very less need of vasopressors, and they had only 5% mortality. The beta phenotype were mainly older patients who had renal dysfunction, and they had 13% mortality. The gamma phenotype had more inflammation and pulmonary involvement, and they had 27% in mortality. And the delta phenotype was the worst, with liver dysfunction and worser shock, with almost 40% mortality. So to conclude, we would say that sepsis does not exist singly. Sepsis exists as many of 4 different sepsises. Okay, so there are 4 different phenotypes that we have. So where is the problem now? The problem is that we cannot translate this complex situation or this complex phenomena into a simplicity or a simple way of saying that there are just 4 phenotypes. Because though sepsis may be one syndrome, it has multiple phenotypes which we may still not do, which we may still not be aware of, and eventually all of these will be with different treatable characteristics. And the another problem is that one size does not fit all. So then there was another trial which was made on this genetic analysis, and the authors here tried to find out the relationship between the adrenocortical candidate gene expression with the clinical response, that is the clinical outcomes, as well as this gene expression to the response to hydrocortisone therapy in these shock patients. So almost 671 patients were initially included from 28 ICUs, and 494 were finally analyzed. And the authors did not find any difference in mortality according to the gene expression, either alone or whether the steroids were used or not. But they did find a significant interaction between gene expression and the time to shock reversal upon giving hydrocortisone. And this was mainly linked to 2 genes. There was the strongest association with GLCCI1 gene, and the other was the VHSD1 gene. This interaction was also found correlating to 2 other genes, that is CRH and LINK, and the long name that is there. But then when a post hoc sensitivity analysis was done, these 2 genes were not found to be correlating or having any significance. So finally it was concluded that 2 genes, that is GLCCI1 and VHSD1, are the 2 genes which are significantly associated with the hydrocortisone response to reversal of shock. So how or why do you think these alterations in the expression of the genes will relate to our adrenocortical physiology, or will relate to the tissue resistance that is there to corticosteroid administration or to corticosteroid action? So though we do not know the exact function which is there by this GLCC1 gene, which the protein that is encoded by this gene is not very clear, it has shown to play a very important role in the glucocorticoid signaling. And it has also been shown to associate with alterations in the steroid responsiveness in numerous other conditions. And this altered expression in vascular endothelial cells is associated with hypertensive response to glucocorticoids. The authors also observed an interaction between the treatment group and gene expression in time to shock resolution between these two genes, and this was, as I said, more with the JLCC1-4 gene. Whereas with the ones with D1 gene, they found that giving hydrocortisone had a slower reversal of shock compared to giving placebo. So there were quite good strengths of this study. That was this study followed a pre-specified protocol of a rigorous blinded RCT, and it used limited number of biological genes, and the outcomes were statistically rigorous, and there is very less chance of false positive findings. Another study which is also recently published has been shown that what they did is they analyzed the Porticus and the Vanish trials, the patients who were included in these trials. They retrospectively looked into the available transcriptomes of these patients or these subjects, and they studied the 11 genes which were also studied in the previous trial, and they were able to find some data for the two genes that we mentioned, but for the other genes that were eventually disregarded. However, they found no significant interaction for any gene with hydrocortisone therapy in the mortality outcome in Corticus trial, as it was found in the Cohen et al. Trial. Okay. But to conclude, these cohorts were very small, and unfortunately, neither of these cohorts had mentioned shock resolution as a publicly available outcome measure. So what is the future? The future is of transcriptomics that may allow identification of steroid responsive subgroups in sepsis. And these findings, however, need to be further replicated across different clinical settings in a broad range of demographics and clinical features, that is even the site of infection, and to better understand the generalizability of the signal that is there. And how do we help in the clinical practice? Well, not as desirable a goal as what we call as decreasing mortality or improving survival. A low-cost rapid test, that is a low-cost rapid RT-PCR, will help us identify a subgroup who will have a faster shock resolution when steroids are administered, which will improve outcomes as well as the lower the cost of therapy. However, before putting to clinical practice, a rapid diagnostic test needs to be made and also need to be validated in larger trials that is there. And a prospective randomized intervention study which shows improving outcome based on the validated rapid test would be necessary prior to implementation in clinical practice. So to conclude, this is the era of precision medicine in sepsis, matching the right therapies to the right patients. Thank you so much. Because currently we are not using the genomics. We will give for the right patient and see the response.
Thank you, Dr. Chanchalani. Any questions?
No, we want to see response.
Hello, madam. Small question.
Yes.
In the first slide saying that there is decreasing evidence toward the use of steroids in sepsis as per the advertisement. But previously somebody was telling that the recommendation is got strengthened in this.
So the current sepsis guidelines do not mention use of hydrocortisone in sepsis, though we still continue to use it in our patients who require higher doses.
But the previous two sessions they told that there is increasing evidence.
So I think we need to point out who they were actually.
Which one is correct? You have to identify.
I was not there for the session.
The strength of the evidence has gone up.
Yeah, 2021 guidelines that strengthen the users.
Yeah, use of steroids.
There is no mention of steroids.
No, it was there. Like, you see the 2021 they have mentioned. Actually, previously used to use steroids, and now there is usage of second vasopressor and also fluid resistant and everything also. But now they say even on single vasopressors you need to use steroids. They didn't mention anything about fluid resistant.
Serious.
It was strengthened. That is one of the
What I read through the guidelines specifically, there was no recommendation for use of steroids. Though they say there is no recommendation.
It was strengthened actually. It's not.
Makes any difference because there is no new evidence which is coming, right? There is no new evidence which is coming either in favor
No, I'm talking only about SSG guidelines. What is the strength of recommendation when it is receded, the strength is gone as compared to 2016?
Whether somebody is very strong recommendation or weak recommendation, you all will do.
No. Will they clearly mention what type of recommendation it is?
No, the level, see, there is the level of see, that is the tragedy with the surviving sepsis guidelines. That is the tragedy with the surviving sepsis guidelines. You have strong recommendations based on weak level of evidence. Right? And you have moderate recommendation based on strong level of evidence. And you have weak recommendation based on very strong level of evidence. So that is the whole story about we should not get mixed up with what level of evidence they have quoted versus what is the recommendation they have made. Yes, if it was a weak quality of evidence, probably in the 2021 it has gone to moderate level of evidence, but it has not made its name into a standard recommendation to say you must use steroid for patients with sepsis.
Just a minute, sir.
Yeah, please read it.
0.58.
This book looks more like a legal argument. Clause 22A of section this and under judgment this.
What is a weak recommendation?
No, it's not about weak or moderate or strong recommendation, it's about the strength of recommendation as raised from 27.
No, please read. Please read. If you have it on your.
58.
Section 304A of
But my request is that I would not leave today's meeting without knowing, without getting some clarity. Okay,
You can stay here.
So it is earlier it was a moderate recommendation, now it is a moderate level of evidence but a weak recommendation.
Repeat.
It's a moderate level of evidence with a weak recommendation.
So that doesn't say that it should not.
No. So if you are convinced that if a guideline of that nature of a surviving sepsis campaign makes a weak recommendation on which you will not change your treatment, then we will follow. There is no issue. It's an individual choice, right? So that's what I'm saying. You look at glycemic control. There is robust data. We saw in that presentation by Sharmili. There is good evidence that glycemic variability is the most important predictor of adverse outcome in septic shock. It's not a blood sugar of 80 to 140 or 80 to 110, but that doesn't come anywhere in the surviving sepsis guideline recommendation. Variability is a passing mention in one of the footnotes of glycemic control. So that is the tragedy of the surviving sepsis campaign. They have picked up information which they want to project. They have picked up data which they want to highlight and made it a strong recommendation when the level of evidence is weak. What they don't want, they are not personally in favor. They have put it as a weak level of recommendation on, even though the evidence is moderate to strong. So if you want to follow what is the level of evidence and make your own judgment, then the decision is different. But you want to stick to what is their recommendation, weak, strong, good, you can follow that level of. But what both the speakers said today is correct. One of them quoted exactly verbatim from the guideline and said the evidence has become from weak to moderate. But still, what Gunjan is saying also is correct. They have not made a recommendation to use steroids. Right? So, Achyut, hope you will go home.